Hello, everybody. Thank you so much for joining us. My name is Neil Bettridge. I'm Senior Director at the Global Alliance for Patient Access, GAfPA. And this webinar is being brought to you by GAfPA in conjunction with ASIF, the Axial Spondyloarthritis International Federation. And today we're going to be looking at the topic of the context of axial spondyloarthritis, looking at personal experiences and data, and also whatever application these issues may have for other inflammatory conditions. So let's take a look at the objectives. The objectives today are really to highlight what the benefits of remission for people with inflammatory conditions like axSpA could be, and why it's so important to achieve the best possible control of the disease. In doing so, we'll have an overview of the condition and the challenges that people living with axSpA regularly face. We'll look at what the data tells us about this, and we'll hear directly people affected by the condition. And then at the end, after we've heard all of that, we'll put the topic of remission into the context of what we've heard and see what we can all consider doing going forward if we feel we want to get involved in addressing these issues. So let's take a look at the agenda, and in a few moments, I'll be passing to the first of our speakers from ASIF. That will be Joe Lowe. And as we go through the agenda, feel free to put in questions and comments into the Q&A panel, not the chat, but please in the Q&A channel at any time. We'll be having a Q&A, a question and answer session at the end of the meeting. And so we'll be taking a look as we go as to any issues you want to raise. So Joe will introduce herself, but is from the staff team at ASIF, and we'll be looking at the data. And then we'll hear from two board members, Lillian and Nadia, before I come in at the end for conclusions and questions. I know many of you will know GAfPA, but very briefly, a quick overview for those who don't. GAfPA is it's a not-for-profit global organisation which essentially brings together key stakeholders in health conditions and healthcare topics with a common interest in policy issues. That may be specific to a disease, or it may be a more overarching topic. So by convening meetings in person and online of patient advocates and healthcare professionals and others, we help stakeholders figure out what the unmet needs are in any particular domain, and then work with them to try to provide resources that support you guys, like ASIF, as the experts in any one field, to raise awareness and deliver advocacy, supported by some of the materials we develop alongside, such as these webinars, videos, blog posts, infographics, and so on. And we work across a whole wide range of disease states. So with no further ado, I will pass to Joe, please. Perhaps you'd introduce yourself briefly, Joe. Thank you.
Thank you, Neil, and thank you to GAfPA for this opportunity to talk to you about why pursuing remission in axSpA is so important. So as Neil said, my name is Joe Lowe, and I'm the project manager at the Axial Spondyloarthritis International Federation. I'll tell you a bit more about the organisation in a few minutes. But first of all, what is axial spondyloarthritis? So you may also hear the disease called morbus Bechterew or ankylosing spondylitis, and the shortened version of the name is axSpA. It's an inflammatory rheumatic disease for which there is no cure, so the disease is lifelong. It primarily affects the sacroiliac joints and the spine itself, causing pain and stiffness in the lower back, but for some people, the whole of the back. The pain and the stiffness tend to improve with movement, but get worse with rest. And it can be particularly bad with extended periods of rest, such as overnight. So many people with axSpA really struggle to have a good quality of sleep. Symptoms of axSpA usually start before the age of 40, but often in the 20s or even earlier. Hip and buttock pain can also be present, and the disease can affect other areas of the body as well. People living with the disease also often experience high levels of fatigue. There is a significant burden of living with suboptimally controlled axSpA. As well as the pain and the fatigue, there can be significant psychological distress, and the disease can also cause difficulties in everyday activities, from working life, socializing, travel, to household tasks, relationships, and family. Usually medication is used to try to control the symptoms of axSpA, but physical movement is also important to alleviate the symptoms. When people living with axSpA see their doctor, the level of what we call disease activity is usually measured using patient-reported information and sometimes biomarkers like blood tests to measure inflammation. Disease activity typically assesses symptoms like pain in different parts of the body, fatigue, and stiffness. The target in axSpA treatment should always be the lowest possible disease activity for each individual. For some people, reducing disease activity to low levels is enough to be considered remission. However, this can be difficult to achieve, particularly when comorbidities or other manifestations of axSpA are involved. We know from GAfPA's Value of Remission report from April last year that remission is beneficial not only in reducing pain and physical symptoms, but also for general quality of life, reducing healthcare system use and increasing prosperity and productivity for each individual. And so, in order to evidence these benefits of remission in axSpA, we're actually going to look at the opposite to low disease activity, and we're going to look at what high disease activity looks like. You'll see from the evidence why lowering suffering by controlling the disease well is absolutely crucial for quality of life. And we'll look at those data in just a moment. But first of all, the organisation that I and Lilan and Nadia have the privilege to be involved with is Axial Spondyloarthritis International Federation, as Neil said. We're called ASIF for short. Thankfully, we do have a short title as well. We're the global umbrella organisation bringing together patient associations from around the world that work to improve the lives of people living with axSpA. And as you can see from the map and the slide, we have 56 members in 45 countries across 6 continents. Our vision is a world where everyone affected by axSpA lives their best life. We work to do this by aiming to strengthen and empower the global axSpA community, working to improve awareness of the disease. The lack of awareness of axSpA is a huge problem and creates many challenges. We also aim to be the global voice for axSpA patients and endeavour to incorporate that patient voice with whoever we're working with a range of stakeholders. One of our biggest annual efforts is World AS Day, which is an annual day dedicated to people living with axSpA. It's celebrated across the world on the first Saturday of May. So this year we have the 3rd of May. Last year it was the 4th of May. Our members and supporters organise activities around the world to raise awareness of the disease and also the conditions that people tend to have related to axSpA. We run a number of other campaigns and projects, such as our Delay to Diagnosis project, which focuses on finding solutions to the unacceptable length of time it often takes to get a diagnosis of axSpA. And every 2 years, we bring our members together to meet for the ASIF Council meeting, the last one of which took place in Bogota in Colombia last year. One of our biggest activities is the IMAS project, which is where we find the evidence that I'm going to present to you today. So IMAS is the International Map of Axial Spondyloarthritis. It's a global survey of people living with axSpA. It covers a range of topics, as you can see from the slide from the box on the right-hand side. The survey aims to better understand the burden of living with the disease. Historically, we've had a lot of information, a lot of scientific evidence of the physical symptoms of the disease, but not the overall burden of daily activities and daily living with this disease. IMAS has been used to provide this evidence through scientific dissemination at congresses and in peer-reviewed journals, and also through ASIF, our reports, our outputs and information, and our members have also shared a lot of this information and been very involved. So the survey collected data from over 5,500 people in 27 countries across 5 continents. One of the ways that disease activity is regularly measured in axSpA is with the BASDAI, which is a patient-reported outcome with 6 simple categories. The 6 categories you can see in the slide here on the right-hand side. each of the categories are scored out of 10. And with an overall score of below 4, so an average score for the categories of below 4, this is what most rheumatologists will consider as low disease activity. In IMAS, 75% of respondents had a BASDAI score of over 4, with the average score being 5.4. And this demonstrates that the vast majority of respondents are still suffering with axSpA that is suboptimally controlled. Interestingly, the average score for each of the 6 different categories is still above 4, and fatigue, neck, back, and hip pain tend to be the most burdensome of those categories. Now, another huge issue for people living with axSpA, as I just mentioned, is the time it takes to get a diagnosis. Lilan is going to talk a little bit more about diagnostic delay shortly. But here we have the evidence from IMAS that tells us that globally, it takes 7.4 years on average to get a diagnosis. This time is measured from the first onset of symptoms until the formal diagnosis. This has a huge impact on the likelihood further down the line of controlling the disease. We can see here the data showing that levels of disease activity are linked to the time it takes to get a diagnosis. And an even stronger link seems to be present between diagnostic delay and functional limitation or spinal stiffness. If we look at those links, we see, for example, that people with severe spinal restriction have an average diagnostic delay of 9.1 years, whereas those with no stiffness have an average diagnostic delay of 3.7 years. I think that is really, really compelling evidence. Not only does higher disease activity make it harder to achieve remission, but for some people, these issues of functional limitation and spinal stiffness may never improve. And that is because the longer it takes to get a diagnosis and receive effective treatment, the more likely you are to develop spinal fusion or other irreversible physical damage. IMAS also shows us that the psychological health is hugely affected by living with axSpA. 60% of respondents indicated the presence of some form of psychological distress, and yet 2/3 had not visited a healthcare professional about their mental health in the 12 months prior to completing the survey. The most commonly reported comorbidities out of all physical and psychological comorbidities in IMAS were sleep disorders, anxiety, and depression. And you can see from those statistics there that almost half of respondents to the survey had a sleep disorder. Aiming to achieve remission by lowering disease activity is, of course, also likely to have a very positive impact on mental well-being as well as physical health. And finally, we could also see a direct correlation between levels of disease activity and use of the healthcare system. For people with well-controlled axSpA, which is the first column of numbers with a BASDAI under 4, you can see that they had fewer visits to all types of healthcare professionals in the previous year. We see evidence in the second column of numbers for those with suboptimally controlled disease, that visits to family doctors were almost double those of patients with better controlled disease, and clinical nurses and physiotherapists were also visited around 1 3/4 times more frequently. And so when we look at this very clear and compelling evidence that demonstrates the burden of living with poorly controlled axSpA, we can see why effective treatment and the pursuit of remission is so fundamentally needed with this disease. Just to remind you that this is a disease that usually takes hold in a person's 20s, meaning that you have to live with it for the vast majority of your life. Can you imagine living with a poorly controlled disease that affects almost every aspect of your life for 50 or 60 years? On that note, I'm going to hand over to Nadia, one of ASIF's trustees, to talk a little bit more about her experiences. Over to you, Nadia. And Nadia, you're on mute.
Yeah, I think Leland will go first with her perspective, and I'm next. Yeah.
My apologies.
Okay, that's fine.
No, thank you. Yeah, no problem, Joe, at all. That was fantastic. We need data so badly here in order to support advocacy message to policymakers. And things like the amount of time people have to wait for diagnosis is really quite shocking and a real stark illustration of unmet need. So thank you so much for that. And yes, that links, I'm sure, really nicely to our next presentation. Lilan, please. I know you want to speak to us directly rather than give us more figures at the moment. over to you.
Thank you, Neil. And first of all, my name is Lilland Warmskog. I'm the vice chair of ASIF, but I'm also in an organization in Norway called SPAFO Norge. I'm very happy to have this opportunity to speak about remission and disease control. I strongly believe that this is the topic that we should speak about in the future. This is very important. But like Joe said, I'm going to also talk about the delay to diagnose. We know today there's a delay to diagnose in many countries around the world. And this also happened in Europe, and it is also happening in Norway. But axSpA is a very difficult disease to diagnose. It isn't just to have a blood test and you get the diagnosis. You did MRI, you need to see a rheumatologist, and you probably also need other exams. But to go a long time without being diagnosed, that does something to your body. You get not so many mobilities in your body, your spine can grow together. So get early in to get treatment is very important. And also to get control over your pain and also to get a better quality of life. But in order to see remission and disease control, it is to have access to the treatment, you need access to medicine, but you also need the access to see a rheumatologist. But for some patients, it takes a lot of more access to get remission. They need more follow-up in the health system and also more medicine. But it is important that those people get more care so they can have a better quality of life. And also another thing that is important when you're diagnosed with a chronic disease, because this disease, you live it all your life. It doesn't go away. Even if you're good treated and have remission, it is still in your body. It's also important to have good knowledge about your disease so you can take better decisions about your life. But it also has been pointed out that to achieve remission and disease controls for this patient, it also gives a benefit to the society. And it also gives a benefit to a lot of people that can stay in working life longer. And also that will aim the society if they get more income. And I think in the end, I'm going to say that for the patient, this is super important to get control of your disease, but it also is a huge benefit for the societies around the world that more patients receive more disease control. Thank you.
Well, thank you very much, Lilland. You've raised so many policy issues there, but in the context of a very human experience. And just like the data told us, this stuff matters. It makes such a difference, and time is so precious with inflammatory conditions as well. So thank you for illustrating the importance, amongst other things, of delays to diagnosis and the damage that can have. Thank you. And then finally, from our ASIF speakers, for more both personal and professional insights, it's my great pleasure to pass to Nadia. Nadia, please introduce yourself. Thank you.
So, hello. I'm Nadia. I'm a trustee of ASIF also, and I'm going to carry on from the two previous speakers of ASIF, and I will contextualize a little bit because what actually Joe mentioned before about the comorbidities of living with the disease, which I actually live for 23 years now, they are here with us. We live with them every day, and they are like the most common are sleep disorders, as mentioned, depression, anxiety, and most of the patients are at risk for psychological disorders in general. So if we go to the next slide, please, we can see that when we go to the doctor's office and we have to discuss about treatment targets and what we actually want to receive and what is remission for us and what is for the doctors, we kind of agree, semi-agree, or disagree with the rheumatologists because they refer to remission or low disease activity by depending on ASDA scores, which are actually rheumatologist scores, like they use actual visible scores depending on our blood tests, our MRIs, and inflammation indexes. And we may depend on other scores, or maybe we refer to our quality of life and how we live our lives, and if we are able to do what we want to do on our everyday life. So at some points we may not agree, or as I said, we maybe agree with some points, and there might be gaps when we are discussing what we want to achieve and what they want to achieve, and there might be some differences or even gaps, as I mentioned. So if we go to the next slide, please, we can see that achieving remissions or low disease activity for us, it means actually being able to achieve lower pain levels that leads to more freedom for us to move and to better functionality. And when we can function better in our daily activities, we have more daily successes. And what we actually mean with successes, that could be a lot of things for several people, but we do have better sense of accomplishment, and that could lead to higher level of confidence. And when we have higher level of confidence, we might get more chances of socializing, to go out with friends, to go out with people that we want to go out, and we don't stay home being isolated. And that could lead to more possibilities for searching for work for people that do not actually work. So we have a higher level of workability and socialization, and that leads to more autonomy, to higher levels of independence, and to lower levels of possibly depression, disability, which actually leads to better quality of life. And as you can see, if you read in the GAfPA the PDF that they have made, it's an actual very nice resource if you want to maybe research a little bit and look at it. If you have like less fatigue, better sleep, you can actually have better quality of life in general. And this is what we aim for. And this is not in total contrast with our doctors and physicians, but this is something we need to discuss and be clear about. So if we go to the next slide, please. The treatment and disease management should not be one size fits for all approach for us patients. So we go to the doctor's office, and I don't mean that the physicians treat us like that, but they might have some specific scores, specific indexes, and specific things they need to achieve by using medication and by using all these amazing treatments that we do have today. But people are unique. Every patient profile, as Joe mentioned, as Leland said, and even as Neil said at the beginning, every patient profile is so unique. So that needs to be always in consideration. So when we take part in the shared decision making process, we need to make it as individualized as possible, taking into account lifestyle of each person, personal goals, preferences, limitations, specific needs, the patient pain and psychological phenotype. This is, as I said, the specific profile of the patient. And even if we're talking about remission on the lowest possible disease level, that's somewhat similar for us, because a low disease level, it's if we're saying like it's a low pain level, so a low fatigue, it's a good good night's sleep. So that's good for us. So it's similar to having a better quality of life. So success may define differently for us, every patient differently, and even differently at the continuum of time. So it could be different today for me, and different in a year's time from now. So this always needs to be in our mind and in the doctor's mind, and this always needs to lead to an open conversation, a two-way discussion, and all aspects should be on the table and agreed upon and explained thoroughly from the beginning. So that is a good way to reach a successful and a good outcome for the patient. So thank you. Sorry, just a quick comment. In a month's time, 3rd May, it's World AS Day. Let's wear orange shoes and join the movement of spreading awareness about AS. Just wanted to mention that. Thank you very much.
No, absolutely. You're very welcome, Nadia. Thank you so much.
Yeah. Just put on orange shoes, take pictures, and join the movement. It's easy. Go on to the website of ASIF and learn more.
Thank you.
Yeah,
Thank you so
thanks.
much. And as you rightly say, Nadia, patient-centered care is got to be the way to go here. Scientifically, we're getting more and more personalized medicine, but where is the parallel development in terms of really treating the person holistically? So this is, I think, absolutely integral to this. So these discussions today have been part of a bigger conversation that GAfPA has been conducting now for a year and a half or more, where we've been talking to stakeholders in different settings, including alongside congresses like EULAR and PANLAR and APLAR, and we'll be doing that again this year to keep the conversation moving. But I wanted to quickly share what we've heard so far and check in with you on that. And there's a big consensus that we're hearing from all the groups we're working with that the key benefits of remission include a very welcome reduction of stress on healthcare systems that are already overburdened with workforce shortages, aging population, and so on. We can identify patients that need and would benefit greatly from earlier access to good treatment, and that's going to benefit not only the patients, but actually the healthcare system as a whole. And the most important thing in all of this is the improvement in patients' quality of life, which is possible if they achieve the best possible outcome. For some, that will be remission. Others may not achieve that, but it's the pursuit of remission, which we think everyone has a right to expect from their healthcare practitioners and systems. And if we do that, we'll have more people optimally treated, and it's suboptimal care that is wasteful, right? So if we agree these are some of the major benefits that would come, what can we do about it? And so far, we've heard from our colleagues, friends, and stakeholders that it's these things which are emerging as some of the major things that we can do and we can ask policymakers to do. One, like I just mentioned, is ensuring more people have early intervention and get early diagnosis. We know that's critical to getting patients to remission, or at least to the best possible state. There's absolutely, rock hard scientific evidence for this. We need to be making that happen more. And if only all patients with inflammatory conditions like axSpA could be treated according to the best practice clinical line, because all of those guidelines do recommend early treatment and the right access for the right patient to the right treatment at the right time. And yet we know there's a huge deficit there. That's not happening at all at scale. As has been mentioned in the presentations today, high quality, accessible information for patients to help them navigate the healthcare system, to understand their condition, to self-manage, to participate in shared decision-making, and to understand their treatment options is crucial. This is what empowerment means in practice, and we need more of it. But none of this is going to happen unless there's greater public awareness. About presenting to your doctor earlier, for your primary care practitioner to know that this may be the early signs of an inflammatory disease like axSpA, to take us to the next point here, actually, which supports better and quicker and more appropriate referrals to the secondary care, which is crucial if you're developing a new inflammatory condition. And the person, the patient, has to get it right. And it's getting it right that will bring the better quality of life and the healthcare system benefits in terms of efficiencies. So last slide from me is the announcement of a new information product resource from GAfPA, which has gone live a few minutes ago. It's released today. So there's the QR code. I believe that gives you direct link to it. Even a screenshot I hear from this will get you to it. Otherwise, you'll see it at gafpa.org on our website or through channels on LinkedIn and Dex. And we're really just putting many of the issues we've heard about today into a format which is evidence-based and we hope easily accessible. So please take a look. If you like it, if it's useful, please share it, pass it on, use it. It's for you, right? We've developed this for your use as you see fit. We're coming up to the half hour, but I would love to take some questions. I think there's been a few coming into the Q&A. So let me just take a look. There's one asking from somebody in Colombia about getting involved. I think contacting the Colombian National Association, Juliet there, or otherwise go to ASIF. Also, something around, Joe, maybe I can come to you on this. Something about the role of ASIF in taking actions. I've just described some policy recommendations that GAfPA's working on that relate to this whole range of inflammatory conditions. But from ASIF's perspective, what's the role of ASIF in supporting it to take actions on some of these issues?
Yeah, it's a really good question. So we produced, from the IMAS data, we produced a report last year, at the beginning of last year, and actually we have some calls to action in that report that really closely map onto the calls to action that GAfPA have produced in your Value of Remission survey. And I think what ASIF need to do through our members, and really promote at a global level is some of these calls to action. And what we've included in our global report, The Burden of Living with Axial Spondyloarthritis, the calls to action are aimed at policymakers and at those that manage healthcare systems. So it's really around getting the message across at a national level and at continental and global levels that policymakers need to prioritise multidisciplinary care. They need to have systems in place that promote multidisciplinary care and early access. So going back to what Lilan has said and the evidence that we've seen, it's really, really difficult to achieve anywhere near remission if you have to wait 5, 6, 7, 8 years for a diagnosis. And so it's about making sure that there are systems in place that have effective referrals to a specialist. And then it's also this around, as Nadia's spoken about, treating people as an individual, having individually tailored care plans. And that's something else that we're trying to, in our work with healthcare professionals, we're really trying to promote, ensuring that people are treated as individuals and that they have the right set of specialists and doctors for them to help to lower disease activity.
Great, that's really helpful. A lot of synergy there then with the global agenda from our perspective too. So great.
Absolutely.
And we're up against the time, but I would like to squeeze in one more question that's come in. Lilan, to you, I think, and it follows on nicely perhaps from Joe's thing there. Thinking from a national patient organisation perspective, what do you think your role is there? So in your knowledge, but what might other patient groups also be doing around this agenda?
No, I think all patient organizations, not just ASIF, but all of us has a huge responsibility to provide safe and good knowledge. And I think when you live with a chronic disease, is one thing is to get the right medicine and you're going out of the doctor's office. You're going to live with this with your whole life. A lot of things is going to happen, like fatigue. You can get other diseases like IBD, psoriasis. And I think if we provide good and safe knowledge how you're going to live your life, I think you better off your quality of life and you will make a better decision about your disease.
Wonderful. Thank you. And so precise as well. If I remember back to when I developed juvenile arthritis, there was no treatment beyond aspirin. It's great that these days there is, pretty good care finding its way to many patients, but actually pretty good care shouldn't be the enemy of optimal care. Why should anyone settle for
very good
when better mighty to support that? So thank you. Thank you to you guys from ASIF for being wonderful partners in this. Thank you to AbbVie for the support which made this possible, but mostly thank you, the audience, for joining in today. There will be a podcast of this on the GAfPA website, gafpa.org. Please, again, if you want to review, pass on, use it, it's built for you to use. Wishing you a wonderful rest of the day, and thank you again for joining us. Goodbye.